So
Hello.
good afternoon, everyone, and thank you for joining us for the third session of the 2023 Winter Spring Third Age webinar series. The Third Age Committee was created in the late 1990s by Health and Human Services professionals from across New York State who were committed to advocating for and spreading awareness of the needs of older adults with IDD, intellectual and developmental disabilities, through educational activities. My name is Laura Robinson, and I am the current chair of the Third Age Committee, as well as the program coordinator for the Finger Lakes Geriatric Education Center at the University of Rochester in Rochester, New York. So just a couple housekeeping items before we begin. There are two very important buttons on your toolbar. Please use the chat button. This will allow you to type hello, introduce yourself with a name, job title, agency, location, whatever information you'd like to share about yourself. We have people from across the state joining us today. And then there is the Q&A button that will allow you to type in a question for the presenter. We ask that you use this button at any time during the presentation to ask a question, so the question does not get lost in the chat. We will definitely have time at the end of the session for questions. And you may have noticed that I am not Sarah Catalano. Unfortunately, she is feeling a bit under the weather today, so I will be your moderator for today. And it is my absolute pleasure to introduce to you Dr. Paul Cabral, today's speaker on accessing OB/GYN care for individuals with IDD. Dr. Cabral is board certified in obstetrics and gynecology, family practice, hospice and palliative care, and clinical informatics. And he earned his biomedical engineering and medical degree at Boston University and completed residencies in obstetrics and gynecology and family practice at the University of Rochester. Along with his clinical practice, residency teaching, and clinical informatics faculty duties, he is also a medical director in the Health Informatics Department at Rochester Regional Health. Dr. Cabral believes in accessible health services in a comfortable and respectful environment, providing care for everyone at a high level of awareness, sensitivity, and skill. And to make this goal a reality, he started the Gynecology Care Center for Women with Disabilities at Rochester Regional Health. This center focuses on respectful and compassionate care, offering accessible health services in a truly comfortable and respectful environment. Dr. Cabral's team brings a high level of awareness, sensitivity, and skill to the care center, which caters to women with cognitive, neurological, and physical disabilities. Appointments last about an hour so that every patient gets the time and resources she needs for the best possible care. With accommodations such as adjustable beds and a closely integrated relationship with dentists and other medical providers, Dr. Cabral and his team are committed to removing barriers to physical wellness. Thank you to Dr. Cabral for taking the time to be with us today, and I look forward to learning more about the work you're doing at the Gynecology Care Center for Women with Disabilities and to your questions and dialogue following his presentation. So without further ado, I turn the session over to Dr. Cabral.
Hi, everybody. Welcome. And I'm glad that you want to learn about this. I am happy to give this presentation. So the reproductive health care for women with disabilities. I took a lot of our presentation from Dr. Cox, who is an obstetrician and gynecology who practices in ACOG's Committee for Underserved Women, along with Dr. Signor, who also is on that panel. And then I tailored it to sort of our local location. So what we're going to do today is we're going to really talk about the history of our clinic, tell you some funny stories, identify some characteristics about the populations we serve, some special considerations, some major health issues that are unique to women with physical, developmental, and sensory disabilities. We'll talk about some medical issues requiring special consideration in approaching that care, and then things that we do to facilitate the care of those patients. So disability is defined as a physical or mental impairment substantial to limit one or more life activities. Now, the interesting aspect of how I got into this world was my wife. So my wife's a practicing geriatrician. And one day she calls me up and says, Paul, I need you to see a patient. And I said, okay, send that patient on in. And so she booked the patient. And the next thing I know, the patient comes into our office, and my nurse is running down the hallway to call me and says, Dr. Cabral, we have a problem. And I said, okay, what's the problem? Let's go figure this out. Well, your next patient's on a ventilator. And so that was interesting. My wife neglected to tell me that this patient was on a ventilator. However, she was there, and I calmed my nurse down. I said, oh, the person came with a respiratory therapist, and we're just going to continue to take care of this patient. So we moved our beds around. We took some time. We were able to finagle a way of getting our patient into the exam room, and we examined the patient and did what needed to happen. And so that was that. Then I get a phone call again from my mother. From my wife. And this time she asked me to see another patient. And I didn't learn my lesson, so I said, okay. And this time it was a lady who had a stroke. And again, we did what we needed to do. We saw the patient. And at that time, my chief knew that I was starting to see these more complex patients, and he thought it was a great idea. And so he recommended that we open up our clinic for women with disabilities. And so I said, okay. And we started to do that. And so we went out and started collaborating with ophthalmology and dentistry, GI, and people started to come in our clinic. We got a grant, we got donations. So I'm probably the only clinic that actually has our own Hoyer lift for women with physical disabilities. But we also started talking to a whole bunch of other individuals, and we talked about mental disability and the ability not to be able to do an exam. And so with coordination with the operating room and dentistry, we were able to obtain some time in the operating room, and we coordinate going to the operating room to lessen the impact of that exam and to allow them to do some screening stuff. So that was essentially the beginning of our clinic, and it has continued to many iterations through the decade. And so, it's been very fun, and I can't do it without the support that I receive. So Dr. Doucette is our current dentist who's doing lots of work, and Dr. Speisman was the chair of dentistry that also helped start that clinic along. Rebecca Berg, who's my PA, has been a wonderful support in doing the clinic. And so there's lots of people over the years that I have to thank for helping me maintain this. So, what type of impairment do these patients have, which is what we tend to see. So, so about 12% of those patients between age 16 and 64 has one of these three types of disabilities, physical, mental, or sensory, which is about 11 million in the United States. So by age group, you can actually look, and 63% of them is really severe, and 31% of them need, as they grow older, more and more women become disabled. So it really is an unmet need. And when I started this clinic, we started having conversations, it's difficult to get them into an OBGYN, it's difficult to get exams. There are not many times they were doing this. Now, I modeled some of this clinic after our dentistry friends at the university that brings them to the operating room. And then as a resident, they used to call us to go and do a pelvic exam when the dentist brought him over. We thought here at Rochester Regional that it could go both ways, whether they enter care through dentistry or they enter care through gynecology, that that communication should be open, and that when we bring them to the operating room, we should try to do as much as possible. So that has been one of our most successful integrations, and it really is due to the dentistry department and their willingness to come and help. And Dr. Doucette in particular, who comes in and does their exams, and we do that in a very integrated process to provide care to these women. Now, the reason why there's these unmet needs is because providers are uncomfortable. Thankfully, I have the experience from family practice and OBGYN that allowed me to be more comfortable with more complex illnesses. And I also have to say that Rochester Regional has supported this clinic in order to provide accessibility. But generally, most OBGYN offices and most QHC sites are unable to do what I do due to the lack of support or the lack of beds or Hoyer lifts in order to do that. And the reason why they do that is it really financially is very difficult to show profit. But this is something that we felt as a mission that is very important, and so we continue to do that. So in order to do this, we need to schedule appointments, whether people need more time to walk into the room or need extra behavioral coaxing and not being rushed to get into the room, or when talking to them, it takes more time to gather the information that needs to happen, or we have to do a lot more family conferencing in order to get that information. We also needed proper space in order to accommodate for physical disabilities or safe places for intellectual disabilities. So an example is that we had a dedicated hallway where our patients could come in, and at one point there were hooks there, and that could be a danger to them. And so if they had a behavioral issue, they could hurt themselves if they fall into hooks. We had to take those off the hooks, and eventually we got a grant to bring it to a more accessible place, a better accessible place at our Portland office that has a large exam room, has handicap accessible doors and widths, and it can accommodate both physical and intellectual disabilities. We also have amazing staff, right? Because you need special individuals to understand that what's going on and how to care for these. And so we've had educational pieces around that. We continue to educate them. We talk about how to approach these patients. And so really the staff has been a tremendous help in order to keep them safe, both in transferring or handling any behavior issues and understanding that. And we are continually working on the EMR, as everyone knows, in order to flag these patients to provide some more information to help with the anticipation of the visit. When they come in, we really try to take as much of a history as possible, and many of the group homes or people who have worked with us in the past know we're going to ask these questions, so they're able to bring some of that information or get on the phone with family members. But we really do talk about menstrual history and periods and seizure activity and mood disorders. We also talk about sexual history, and that is actually a very complex scenario where people with developmental disabilities are sexually active, and what are our boundaries, and what can they agree to or not agree to, and so that is something that we have to think about it all the time, and then either plan for or do that. So when someone comes in asking to get their daughter's tubes tied, ethically, is that correct or not? And so we have to go through those conversations and really talk about it, and see what's in the best interest of both the patient, and the family. We talk about gynecological history, reproductive history, and we talk about the past. So the public exam is really a personal space for many individuals, and many individuals with developmental disabilities don't understand a public exam because they just don't understand the need or why, or can't comprehend that. And so we have to really assess whether or not we are capable to do the public exam. We do lots of reassuring, we do lots of coaxing and talking, we do lots of maneuvers to try and not cause any discomforts using lidocaine antidetritus, or maybe some pre-medication if they normally get pre-medication for a doctor's appointment. But if they are unable to do that, we don't try to force the exam in the office. And in that case, our recommendations usually are to bring them to the operating room, where we can then sedate them and then do exams safely, both for the patient and for us. The other issue is really transfer. So for physical disabilities, how do we get a patient onto an exam table? I mean, many of you have probably experienced exam teams kind of high, and you have to step up and get onto it. Well, in our clinic, we all have movable exam tables that go all the way down to the floor that you can transfer from wheelchair straight onto the bed. There is no step. Even if you can't manage those, and then we also have assistants to do a two-person transfer. If they can't, then we do have Hoyer lifts or stands equipment that allows us to then transfer them to our exam bed in order to do that. And so this is a picture of our Hoyer lift. And so getting to know how to use a Hoyer lift as an obstetrician gynecologist was interesting, but our staff is really fast at using it and easy to use, right? We have to assess whether or not can they safely be transferred in the Hoyer lift due to any developmental disabilities, and understanding that, or that. So we do those assessments for safety, because I think that is one of the most important priorities that we have, is making sure that we're not going to harm someone during this. We tried to have them empty their bladder if they can. Most of the time they can't. And we try to do public exams in alternative ways. So left lateral position instead of just normal stirrups, can do a public exam that way. And sometimes it's a lot more comfortable, and people feel a little less vulnerable that way. So the biggest question is, why do we do pap smears on these developmental disabled individuals? I've been asked that question a lot. They're not sexually active. And the answer to the question is, I don't know if they're sexually active. And we do know that the HPV virus is the number one cause of cervical dysplasia. And if you're not sexually active, the likelihood is that you're not going to get it. However, it is not the only cause. And there is about a 5% rate of cervical cancer not related to HPV. And so we believe that women, no matter what their disability, should be screened like the rest of the population. And if we're going to do that, and we need some extra treatment around it, then we should maximize that time as much as possible. And so if we're going to bring you to anesthesia to do a pap smear, which would take me, a very small amount of time, we'll use that anesthesia time also to get their teeth cleaned, x-rayed, and examined, because dental issues are extremely common and can be extremely painful and unrecognized due to the inability to communicate. And so those routine screenings with the dentist, I think, is one of the most important things that we can do. And in fact, so the other components is that when we bring them to the operating room, we just don't do that, right? With the availability, we've had ophthalmologists do eye exams, or we do breast ultrasounds to evaluate for breast cancer. I've had people come in where I've had to look at their spinal rods and do x-rays or blood work. I personally trim their toenails and trim their fingernails and clean out their ears, which are things that can't really be done due to behaviors for some individuals. And lo and behold, I found lots of stuff in those ears that might be kind of interesting to talk about. But so we get those cleaned out, and so that the patient can hear better, or is not irritated by whatever it is in the ear canal because they stuffed it in the ear canal. And so because we believe that women should have that, and we know that 57% chance less likely to have it, that's why we really offer this service to them. And so we think it's an important in order to do that. And so why are they not getting it? Well, I think we have to look at their barriers, which is they can't get on the table due to a non-understanding or just not feeling comfortable, lack of time on the provider's point of view, inability to find a provider who's willing to do it, insurances who don't want to continue to do that. And so the biggest issues that when we come in is, when is it appropriate? Well, we believe that it's appropriate if you're going to do routine screening, and we should maximize it. Now, again, it's a risk-benefit ratio that has to be discussed, and that's the second issue that really we need to talk about is consent, and getting the consent from the appropriate individuals and getting them in a timely manner. When we started the clinic, we would book them and without consents, and then we would never get those consents because sometimes it takes some time to get consent from regulatory bodies, or trying to get consents from their guardians was difficult. And so we booked them after we received consent. And then we have to coordinate time. And so we would have had the ability to now have an OR that's once a month and dedicated to that time, so we can really schedule those individuals versus having to search out time for the OR. So we were very fortunate about having that. So the coordination is pretty easy on our part, is we know it's going to be at this, it's going to be on a Friday once a month. It's like the every fourth Friday. And then we do the best we can. So for example, mammograms, we do not have a portable mammogram machine. But we can do a breast ultrasound instead for screening purposes, because it's better than not getting anything at all, because people, most of the time they don't tolerate going to get a normal standard mammogram. So, and then usually if they need something else. So I'm always available when other individuals need me to come in and do an exam. So they might be coming in for another procedure for another doctor. I will come in and refresh their pap smear. Or I start off, and if they need stuff, then I do that coordination for them. And I also try to take every opportunity to do a pap smear to limit the number of anesthesia events. So if someone else is going in for a case and they require anesthesia, I ask, hey, can I come along with you? I just got to do this quick pap smear. And therefore, I might save 1 or 2 anesthesia events in her lifetime when they come in and see me. So that is the end of my sort of fixed presentation. I'd like to open it up now to questions and answers or comments.
Thank you very much, Dr. Cabral. I appreciate you being here with us today and talking about that. And you answered my question, because I was thinking about when you said cervical cancer screening, what other kind of cancer screenings can you do? And you brought up the mammography or the ultrasound. So that's good. And I know they do.
And colon cancer screening. So a couple of different ways for colon cancer screening. We try to coordinate. Again, it's a hit and miss, and it's really relationship building with other specialists. But for many years, and we're trying to build this relationship back up again, women older than the age of 50 require a colonoscopy. We can do it at the same time that they're getting their colonoscopy, or I bring them in and they get a colonoscopy on my end. So colon cancer screening, fit testing is another one of those things that we would do if need be, right? So sometimes women or individuals, right, go to the bathroom and poop, and they can't get a sample of poop because, just however their behaviors are. When they're under anesthesia and I do a cervical pap smear, I can then just do a quick rectal examination, obtain some poop, and send it off for the FIT testing, which is the fecal occult blood testing, or Cologuard for cancer DNA type testing, so that we can screen that way if they choose not to. So there's a couple of ways that we can do it that way.
Excellent. Thank you. So I do have a couple of questions here that Sarah passed on for me. So what advice would you give to other care providers who are interested in creating a care space that's more accessible, such as the one you created for patients with IDD?
I think first and foremost is safety. Early in my career, I didn't pay too much attention to safety because, right, I just wasn't experienced enough, and then eventually I was more experienced. So I've had individuals where we scheduled their appointment during the summertime or spring and fall where the weather is not bad. So I go out to their car and they're strapped into their car seat because of their behaviors, right? And then, I go and talk to the parents and do as much as I can. Clearly, that person was never even going to be examined at all, but at least it's that visit that I could talk to the caregivers. I think now it is phenomenal, and I hope that we continue with telemedicine. I think that has been a phenomenal thing, right? Because now I don't have to take them out of their environment, right? I can bring an iPad to or a phone or something to them, and they're in their environment, and they're much more calmer, and we're talking to the caregiver. Because most of the time, it's really us having conversations with the caregiver of them. And a few times, the caregiver, well, I'm just the person coming in, and you have to call the nurse. But if you're setting up now a conversation versus telemed, the house nurse can be there, the normal caregiver can be there, and sometimes even the family member can be there, and it just becomes a much more enriched conversation in order to do that. Because a lot of what we do is a lot of discussion. So any of the physical aspects of it, again, might not be tolerable, and they have to come in to get anesthesia. And so that's the biggest thing. So a good telemedicine system is a good thing that I do, a safe space and a big enough space that doesn't scare individuals, and that people can come in and you can have family member groups. And then patients, really, I think that's the biggest thing. These patients take sometimes a long time, and just giving them the time that they need in order to do what we need to do in order to keep them safe and healthy. Laura, you're on mute.
Thank you. Thank you for your answer and for letting me know I'm muted. We did have a question come in through chat. This is from Judy, who says, do you work to get tubes tied of women who are at risk of being taken advantage of, or perhaps have already been taken advantage of? And do we need to go through the courts for permission? If you could talk a little bit about that process.
Yeah, that is a very tricky situation, right? So I would have to argue that many people, all are can be taken advantage of, right? So even in the nursing home where they're, federally regulated, there's just been lawsuits and people going to prisons for taking advantage of elderly individuals. I'd rather have that person out of that situation and work towards moving that patient out of that situation than permanently revoking their ability to have a baby. If that is the biggest concern and we can't do that, maybe I would consider asking to place an IUD, something reversible, something that's not permanent, that could then be removed if the person were to then desire their fertility and have a child, right? So their disability doesn't preclude them from having children, and so parents are really hesitant. Patients, at least in New York, patients reproduce. Right, I can't say for other states, and so that that is sort of an issue. I mean, I had situations where the person wasn't able to consent for having children, and then they were able to consent for having children. And if I had tied their tubes as requested, then I would have created some harm at that point in time. Would I have to go to the courts? I would go through whatever regulatory bodies I need to in order to sort of get permission. I'd also verify it through independent psychiatrists and other providers in order to make sure that we do that. And of course, I would go through our ethical board. Just the last thing I want to do is do something that comes back and said, hey, you didn't do it, not have a documentation. That many people have looked at this and it was a consensus statement of that, because it's such a huge issue, and people can be fall on either side of the fence and where it belongs. I personally believe that if there's alternatives to something permanent, then we should use the alternatives.
Right. So it is a very complex issue. I know, Judy, you put in another caveat in the chat talking about individuals in the community and parents are their guardians, but I think on a case-by-case basis, the decision has to be made with the person's capacity considered, as well as their rights and future rights, depending on their age and what the living circumstances are. Is that what I'm hearing you say, Dr. Cabral?
Yep.
Okay. All right, thank you. So other questions, please add them to the chat or the Q&A. I have another one here for you that says, now that you've been utilizing the care center for some time, what are changes you might want to make in the future to continue improving care for this population?
So I could say I have a dream, right? And if I won the megabucks or the lottery, or someone decided to give me some money, this would be my dream. So I believe in a comprehensive center that would care for all the individuals and allow for both primary care and surgical disciplines to work in those centers. So the center would not only take care of sort of primary care and have a space available for primary care, right, where you can collaboratively work with that, but it also has a space for dentistry, has a space for procedures, in such a way that it's not so scary, right? Even coming into an operating room, in through the hospital, right? At least at Rochester Regional, you have to go through one floor, up to a set of elevators, to another floor, to another room, to another room, right? So sometimes that can be very difficult on patients coming in. And so if there can be a center where it is walk in the first floor, and then have space and safety for anesthesia and to do either dental procedures or gynecology, what ends up happening is that the gynecologist, the dentist, can be working in two places at the same time. They can be working in an ambulatory space, seeing patients, assessing whether or not they can be done without anesthesia, and also be doing anesthesia, right? So for me, I'm in the operating room for 8 hours. My whole time is spent maybe 30 minutes total, because the rest of the time is me coordinating or having the dentist do their job, their work, right? And so I could be seeing ambulatory patients and making those assessments, right? I'd be popping in the operating room, and so it'd be a little bit more efficient. The other thing that happens is that it then becomes recognized as that this is the place to go. And so, people don't get lost. I've had people go to the wrong location when they were scheduled for the operating room, right? So they show up in my office and we have an appointment with Dr. Cabral. I'm like, nope, it's at the hospital. And so that way it really becomes a place where everybody goes to and all the needs are met. And then the team is always together. So the gynecologist, the dentist, the internal medicine doctor, and all the supporting staff, and we can conference and talk about the patients and their needs together as one whole unit, versus more of a sort of, here I work closely with a complex care clinic and I work closely with dentistry. But if we're all in the same room, I think collaboration and care turns out to be a lot better that way. Especially as they get older and maybe their medical needs get a little bit more pronounced.
So we need to get you some funding, is what I'm hearing you say.
That would be great.
Only a few million. All right, let's
Only a
keep
few
playing the
million.
lottery. And then what would you like to tell families or caregivers of patients with IDD to consider in preparation for a visit to see you at your clinic?
Right. So people wonder, if people wonder, why is it important? Well, I think it's important because, we do a lot of stuff, not just screening for pap smears and bringing them to the operating room, right? So we do a lot of menstrual management that can cause some significant behavior changes, right? Individuals with IDD don't may not recognize what's going on with their body, might not associate the discomforts of menstruation, PMS, all those other components that go along with it. And so therefore they don't know what to do. Their behaviors might change. And so many of times you do hormonal suppression of their menstruation because it prevents them from having that discomfort and having that inability to not be able to communicate with that. And so those are some of the reasons that you come in just for the office. It's just not for a pap smear. It's really to assess what else is going on and maybe improve some of the symptoms or behaviors that might be going on, if that's the case. Or it just allows us to touch base that everything is going okay. So as people get older, one of the first signs that things might be coming abnormal is their periods might be starting to change, or they stopped having their periods and then they started having those periods again. And so having them come to be evaluated to make sure that there's no endometrial cancer or worry for the endometrial cancer, because the menstrual change is the only thing, really the first thing that happens. And if we can take care of that in the early stages, then we can cure the uterine cancer versus finding it more on when it's spread and after a longer period of time. So routine gynecology visits are, in my mind, warranted. They might seem trivial, but there are the few important questions that just need to be asked and discussed in order to do that. And that's why I think telemedicine is really beneficial, because I do know how hard it is to get an individual ready to come to an appointment and then bring them back, and all the resources required for that.
So one of the things I've noticed in the last couple of years, I looked up menopause in women with IDD, and there's not a lot of peer-reviewed literature out there about what goes on, what happens. So I know you're talking about menstrual changes, but what are some of the other maybe behavioral changes or anecdotal changes that you hear about in clinic that can help inform staff when they're working with people who don't necessarily communicate these things?
Right. So as the menstrual changes happen, like PMS, we normally talk about PMS and in individuals with IDD that don't have IDD, even some that they just might behave slightly different, right? And so, but eventually we can correlate it to this is their period and this is what's going on, and then people kind of figure it out. So I think that if someone's been stable for a very long period of time, and they're getting older and suddenly behaviors change, right? And there's no other identifiable source for why the behavior has changed, right? Then might want to also think about getting a menstrual diary and recording their periods, and then overlaying what's happening with those behaviors. And that if they start to line up either before or after or during their period, then you might want to think that that might be part of the cause, is that they're starting their change. Technically we are told that someone starts to go to menopause 10 years before they actually hit menopause, right? They're just like, people become go through puberty, it hits a lot earlier than when they start to menstruate, because as the hormones change, same thing as menopause, it starts to wean off and certain things start to happen. And so with those changes, people might not perceive that could be related. And by putting them on some hormonal therapy and suppressing their periods, their behaviors change. Now, does it happen all the time? Does it work? The answer is no, but in that space when you're unable to communicate and if you've ruled out everything else, it's at least worthwhile to think about it. And at least worthwhile to get a menstrual diary and see if those symptoms correlate to the menstruation.
Thank you, because that is an important factor as women get older. So what would you say is the average age range of menopause that you see in some of the patients you work with? Is it
Um,
earlier, later, the same as the general population?
No, they're typically earlier, usually due to some genetic, most of the higher, there's a higher incidence of genetic abnormalities in people with IDD. And so, for example, premature ovarian failure is extremely common in Down syndrome populations and those individuals. So they tend to be a little bit earlier in menopause than a normal typical person would do it. Many a times though, we don't have any history, right? We also are kind of saying, when's your mom gone into menopause? It's usually when you would expect yourself to go into menopause, but many of our patients, we don't have that family history or the ability to do that, either because they were adopted or their parents have passed away and they're in some cardiac caregivers, or the best one is their mom had their hysterectomy. And so, they're like, I don't know, and so we just don't have that information. And so I think it would be very tough to do that study, especially because you'd maybe have to try and get blood levels, which aren't the most accurate way of doing that. And trying to get blood on that population sometimes can be very, very difficult.
Yes. Okay, thank you for that. So I am not seeing any more questions in the chat. So perhaps we will just end a little early today, which I think no one will complain about. So I'm going to thank everyone for joining us today. When you exit the Zoom webinar, you will be redirected to an evaluation survey. We value your thoughts. Please take 2 minutes to provide feedback. I also dropped the link to the survey in the chat. We hope to see you next month on Wednesday, May 17th, when we will be joined by Sarah Catalano, hopefully feeling better, Sarah, and Kimberly Stampone, who will discuss how to navigate end-of-life planning in New York State. So thank you and enjoy the rest of your day, and a big round of applause to Dr. Cabral. Thank you so much. I think this was extremely informative and one of those areas that we just don't often hear about, think about, and discuss. It's still one of those, I think, kind of taboo topics that needs a lot more airtime. So truly appreciate you being here with us. So thanks everyone, and have a great rest of your day.